now we request Dr. Anand Pasadi, the keynote speaker, to give his talk on preoperative and operative considerations in patients over 80 years. After this, we'll be having about 10 minutes for the discussion. 9:15. 9:15.
I think it's a pleasure and an honor to be speaking after so many fantastic presentations, and I basically decided that we'll try and keep the important parts of operative considerations for senior cataract surgery patients. I do acknowledge some of the videos which I have borrowed. So I think now in the present context, we do get a fair number of patients above 80, and this basically presentation outlines some evidence-based strategies. I think the important part is about preoperative, intraoperative, and extremely vigilant post-operative care in this set of patients. And a question is, what are the unique challenges? One is complex medication profiles. An average, at least in our group, 5 to 8 concurrent medications increase the risk of drug interaction, especially in males. We do know about the IFIS. There are some ocular changes where you have reduced pupillary dilatation, zonular weakness, shallow anterior chambers, and in corneal endothelial compromise. The comorbidities, especially beyond the regular cardiovascular diabetes and hypertension, include neuronal diseases like dementia and Parkinson's. Cognitive considerations are important, especially when you go beyond 80. There is a study which says about 30% have some difficulty in cognition, especially if it's a long procedure. Now, pre-operative assessment fundamentals include a comprehensive evaluation, medical optimization with a cross consultation, and a patient-specific risk assessment. You also, of course, tailor the schedule, preferably the first patient. Particularly important is in terms of medication management and systemic disease status, and which I cannot overemphasize, especially beyond patients in 80. When you look at preoperative stratification, one of course common thing is about pupil rigidity, which has actually been mentioned. You can plan for iris hooks, Melgoin, BHEX, whatever works. Zonular weakness, you assess the dynamic phacogenesis assessment and be prepared with the CTR or a modified technique. If you have a dense nucleus, vertical chop adaptation is important. And if you have shallow anterior chambers and ASOCT with a viscoelastic strategy. Corneal and endothelial compromise in this patient, which we found on table, already had Fuchs dystrophy. These can definitely compromise the visual outcome, and you need to adjust the phaco settings accordingly. The latest research, the Anchor study findings show in a cohort of about 1,000 plus patients, the complication rate is a lot more than our regular patients. They're close to about 10%. And with a risk reduction, 37%, you can actually do much, much better. The success rates of increasing, getting 6 by 12 better is almost about 94.3%. So age alone should not be the criteria for determining the surgical risk. I think it's also important about looking at systemic factors. Ocular surface planning, important because most of them will have some borderline dry eye, almost about 70%. And occasionally it's not a bad idea to actually have a treatment protocol of about 2 to 4 weeks, which includes preservative-free tears. Not a bad idea to consider temporary punctal plug. You can also give steroids if you have inflammation. And reassess before the surgery. And if there is epitheliopathy, it's not a bad idea to continue the treatment before you take them up, because a lot of them end up with post-operative inflammation, which may not be vision related, but is very compromising for the patient's ability to see well. The OASIS study, which is the ocular anesthesia safety in seniors, mentioned that topical and subtenons is probably the best approach. You can give monitored sedation. General anesthesia very rarely necessary, but topical and probably subtenon is the best option. Intraoperative techniques, spawn pupil management, usually 42% of patients will have suboptimal pupillary dilatation. And the ARMOR trial demonstrated a 60% reduction in iris complications with mechanical dilatation. So you have multiple options. You can use pharmacological approaches where you have intracameral and of course OVD techniques, mechanical dilatation with the Mulligan, iris or BHEX, which has already been mentioned. And there are some surgical adaptations which include modified phaco positioning, lower parameters, almost about 30% less, and you got to definitely focus on increased chamber maintenance. An important part before starting is to make sure that you check the rigidity of the pupil. So this is a stretchable pupil. If you put a bit of fluid inside, you see the pupil expanding. These patients will actually do well even with a mechanical stretch. There are some set of patients which are not stretchable. These are rigid pupils with pseudo exfoliation, age-related meiosis. These will definitely, even if you stretch, they will break. So you will have a post-op irregular pupil. There is in mechanical stretch, if you can get about 5 millimeters with a bit of viscoelastic and then insertion, usually is a good idea. This is the BHEX ring, quite standard and fairly good to go ahead with the dilatation. The chopping techniques which already been mentioned, I would not mention that, but it's important that you need to decide what is your shape. You can get pentagon, hexagon, you can get square, you can also get round pupils depending on the points of contact. So if you have 8 points of contact, you can get round, but with iris hooks most of the time you will either get a pentagon, you can get a square, you can use extra iris hooks and even go up to a hexagon. Mechanical dilatation of pupil, which already I mentioned, have multiple options. I won't go into that because that itself is a separate course, but the present techniques of mechanical dilatation give actually very, very good results. There are some strategies for weak zonules and shallow anterior chambers. Important to identify it early. You need to have capsular support with a proactive CTR placement. You can use viscodissection to make sure the bag is formed at all times. There are some modification of techniques, which is low flow, reduced vacuum settings, and a nuclear disassembly adaptation, which has already been discussed quite well. I call it an ZOS, which is zonular optimization strategies. You can, if you follow that, you can get a 56% reduction in capsular complications. This is a good video which actually demonstrates the timing. Here in this video, the entire bag is actually moving, and early placement of the CTR probably makes sense. You got to inject cohesive OVD to create space in the bag, and then you use the CTR at this point. The challenge is, of course, because the bag has the nucleus and the cortex, the space is a lot less, but you got to support with a second instrument so that you don't miss the CTR, and you could probably get trying to fish it out as a challenge. So second instrument to make sure you don't rip the capsule is extremely important. In this patient with pseudo exfoliation, you already have a dilatation, and you got to, if you stain the capsule well, this is extremely important when you're inserting the CTR. You always make sure that it goes under the rexus, because taking it out from the sulcus is extremely dangerous. Phacoemulsification parameter adjustments include probably about 20 to 30% reduction, both in your power, vacuum, aspiration flow, and including your bottle height. So when you compare standard and elderly, which is beyond 80, you're looking, you need to basically generate less heat and turbulence, and it's particularly beneficial in fragile elderly eyes. This is more to mention about the depth of the trenching. I think a 4-quadrant is a good technique to learn, though most of us are not very familiar with it. But when you have hard cataracts, which a lot of these 80+ patients have, if they are diabetic or they're beyond 80, you got to really go to the depth of the trench, and you are doing a mechanical dissection. And it's not a, so you don't really need to look for the red glow. You can always go in a 4-quadrant technique, go around, get a depth in the center before you try and crack it, because of your, if you have already implanted a CTR, you can be a lot more confident. So I feel it's a lot more easier to consider going ahead and implanting a CTR when you're not sure how long the procedure would be, what will be the level of your manipulation. There are, of course, IOL selection considerations. Most of them I would suggest going ahead with a single piece or a single piece lens in the bag. But when you're looking at material properties, hydrophobic acrylics probably the best. A prolate or an aspheric profile would work well. Light filtering, blue light filtering lenses an option, but not really that critical. But EDOF can be used if you have patients who require good functionality. Wound construction and closure adaptations, I prefer a larger wound. Strategic placement, which is a temporal clear corneal. You can do an enhanced hydration. You can also consider a small pocket above the incision to actually close it, which is a Wong modification. I have a lower threshold for actually putting sutures. Even if there's a bit of a leak, I would actually go ahead. The post-op is quite standard, not really different, but I would probably keep the NSAIDs longer to reduce the chance of CME. there is one set of monitoring schedules. I do keep them on a closer follow-up, and it's not a bad idea because of the mobility issues to keep them on a phone follow-up. I call it a phone follow-up. That is, you have a video call either on WhatsApp or Telegram to make sure that the initial post-op is quite good. Endothelial decompensation, extremely important because some of them have cell counts less than 1500, and you would have some of them with Fuchs dystrophy. Prevention is use of OVD and using treatment approaches with hypertonic saline. You can consider Rho kinase inhibitors, and probably making sure if you got the endothelial count to warn them about a DSEC or DMEC may be required. On an average, their loss of endothelium is 12 to 15% compared to 8 to 10 in younger patients. So that's an important consideration. IOP management, the IOP rise in a lot of these patients also tends to be more than younger patients. And if you have pre-existing glaucoma, dense cataract, and return viscoelastic material, the risk factors are a lot more. So prophylactic strategies to actually giving them acetazolamide pre-op may be a good idea. I won't touch upon this. Endophthalmitis also, I won't touch upon this, but CME is important because a lot of them have longer surgeries, so you need to have early detection. So routinely we do subject them to an OCT at the end of 1 month. If you have diabetes, if you have an epiretinal membrane, uveitis or a complicated surgery, the odds ratio of most of them does go up almost 3 to 5%, which is less than, which is more than what you normally do. So a longer NSAID combined with steroids. For refractive cases, a subtenon, triamcinolone may be something you could consider. So key takeaways for elderly cataract surgery: you need to have a comprehensive preoperative assessment, you need to have a customized surgical approach, and preemptive complication management. This is important because you can then need to have a better, closer follow-up. To conclude, successful outcomes of cataract in surgeries over 80 requires a holistic approach. You can use multiple evidence-based protocols which is tailored, and an important point is chronological age is probably less important than the physiological status, especially in terms of systemic. Thank you so much for your attention.